we need to know for most of our patients pretty early on what molecular profiles they have. So Paul, at Indiana University, when does a colon cancer patient get molecular profiled and what tests are being done?
Well, historically, we have done most of our testing, at least the basic testing, in-house. We have a large enough pathology laboratory to do that. More and more, though, we've moved to doing next-generation sequencing on all of the patients up front. The trouble is that there's always a lag time of around 4 to 6 weeks, depending on which test you order. And that lag time, is frustrating, even though we, for the most part, know that a 4 to 6 week lag is not biologically or medically important, but certainly psychologically important for patients to wait
So what
around.
markers do you want to know for every colon patient?
Well, at a minimum, we would get microsatellite instability testing. We would get...
On all colon patients? We'll come back to that.
on all colon patients. We would get all RAS testing, BRAF testing, and HER2 now. Those would be the sort of four, sine qua nons.
Everybody nodding? Anything we're missing?
No,
So MSI of some way, RAS, all RAS. And
All
so
RAS.
I think, at least I know in the US world, I see lots of patients who have a KRAS wild type report,
Right.
but not the other RAS genes. And so the answer there is you got to send it again. Is
That's
everybody right?
Yes,
You got to
you
find
have to have
what
all
about
RAS.
20% other RAS mutations
All
or so.
RAS.
So all RAS. And the next gen, what's the approach in Europe for doing this? Is this your own lab? Are you doing companies? Is it getting reimbursed?
Depends on the countries. In what I can say, in Italy, where is a public health system, there are some qualified pathology labs that usually work in a network with an external quality assessment scheme to validate them. And this works pretty well. Obviously, there are regions of the country where the system is much better organized, and so you have the answer in a reasonable time, within a couple of weeks of working time. In some regions where this is still a problem. I guess in most of Europe is like this. To my knowledge, in France is the best organized system because since a long time they established those 28 centers that are designated for all molecular characterization of tumors. And I guess they've been much better in pursuing to get 100% ideally of patients tested, not only in colorectal cancer, but also in other diseases.
Most of the patients that we see with metastatic disease, particularly if they present with a synchronous MET, the biopsy we get is from colonoscopy. And that's the only sample you have, and nowadays we don't often rebiopsy the metastases and things. Does that primary tumor adequately reflect the molecular profile of the metastasis? Paul, you want to handle that?
Well, I think what we know so far is that, so especially in a patient who walks in with a synchronous primary metastases, that most of the time, and really the vast majority of the time, according to studies so far, there's alignment in the molecular features of
So what
those.
we see there
That's
matches
right.
what we see
It's a whole
there.
different story, of course, once patients have been treated, once they've had time with their cancer.
Yeah. Dirk, do you have a difference of opinion at all?
No, not at all. That's it perfectly represents the synchronous metastases. Also represents the metachronous metastases if this is not onset very late.
Right.
We do know.
So you don't necessarily need a rebiopsy after adjuvant therapy? If you have
No,
mets.
I wouldn't. If this is within a reasonable time frame, not 5 years later, then I would say there's no necessity.
So I'm going to actually differ on this position, just to maybe be my usual self. But the more we have been doing repetitive molecular testing, the more we're seeing these things change. And I've even seen two tests, same sample, going to two different companies and getting one's RAS wild
Different
type
results.
and one has a
But
mutation.
this is bad quality assurance. I
Well,
would
so
say.
these are both very good companies that we would quote, one traded on the New York Stock Exchange. So the idea that the test is the test, that the answer, and in every other disease like lung cancer, in breast cancer, the standard is rebiopsy.
But just to push back at you, John, what do you think the rate of
Low.
differential testing?
Very
right.
low. But
5%?
If that. But so
Right.
the question being, if you had a RAS mutated patient, and now it's 2 years later,
Yeah.
and and you're thinking, well, I'm out of things to do, Is this a patient that should be
No, but
rebiopsied?
you're critically right, because we do know that RAS mutation are a negative predictive marker. So we say if we treat patients with a mutation with anti-EGF receptor antibody, we may harm them. And therefore it's critical to see this. It's not only that the treatment is not adding any benefit, it's not that we're only exposing the patient to unnecessary toxicity, we may actually harm the patient. So therefore we really have to ensure this. I'm personally not so much interested into this kind of synchronous versus metachronous different time point biopsy. The question is clear, what do we now learn with the new tools from the cell-free plasma DNA of these tumors? So will this help us
Something
in
that's being
future?
embraced a lot in, say, lung cancer, where mutations can emerge and you change your therapy. But I'm also, seeing the circulating tumor marker people back off their position to say, we're not really good at diagnosing those mutations, but we'll help you follow them. So I'm, that's an evolving.
But there is
field.
definitely a little lack of concordance, even in that lung study. I mean, these are patients. The recommendation would be for patients where you can't access, essentially, with a biopsy. But your point is well taken. The question that remains is, of course, what do you do with discordant results? Let's say you have
you
a
pick
synchronous,
your favorite one.
exactly. But if you have a wild type, RAS wild type liver mets and a RAS mutated, or vice versa, RAS mutated primary, and the colon primary is still intact, what do you do?
You consider mutant. If you cannot,
the worst of the two.
Because
you don't want to hurt the
You treat the metastases, I think,
and
is what you do.
in any case, if the tumor was mutant at the beginning, 10 years later will be still mutant, because RAS mutations are very early in the development. They are founding mutations. So it could be very complex that you lose this mutation. The opposite can happen.
Sure.
So really important, MSI testing, okay? So Paul's saying we got to do it in everybody. Everybody agree? Every colon cancer patient needs MSI testing? How about every solid tumor?
In the ideal world, yes.
In the ideal world, yes.
Every GI solid tumor.
Every GI solid tumor.
Well, because this is what we do. But
certainly all of our patients.
the answer is complex. But I do think that we should test MSI on all patients.
I would want to know. If I have metastatic cancer, I want to know.
If the resources allow, this is the problem. So
Who's
pancreas,
not gonna allow?
let's say pancreas cancer.
Oh, if you have enough tissue.
Yeah, but it's less than 1% chance.
Yeah, and would you
0.5%.
biopsy somebody just for that 0.6% expression?
No, but I tell you, but I have a patient, for example, who had MSI positive tumor, pancreas, but we identified it in the setting of Lynch, so that was easy.
Easy.
Patient had a complete response to a PD-1 inhibitor. So we see those responses, and we see some dramatic responses in some patients who have MSI high, who traditionally don't respond well to chemo or have really bad cancers. But that also is a resource issue. Ideal world, you should test everyone for MSI if you can.
Fortunato, how's it tested in Italy right now?
The problem in Italy that we, as in Europe, do not have registered or reimbursed the PD-1 antibodies for the treatment. And so it's still within clinical trials or in centers where you can have access to any kind of clinical trials that can bring you the drug. Obviously...
so you can't just get it? It's not paid for by the health
Because
service.
it's not EMA approved yet.
Yeah.
And so it's not even...
Will this new approval for Pembro in MSI high tumors change things for you?
You have to consider usually on the average, EMA approval follows about 3 to 6 months on the average FDA approval. And the reimbursement policies are within different countries in different way.
Do you use IHC, or is it more of a gene test?
This is another issue because basically, obviously, you can use by protein expression, immunohistochemistry. You can have genetic analysis. Ideally, you should use multiple gene analysis like next generation sequencing platforms because this will help you to have multiple assessments at the same time. But again, we are in an ideal world, and if you have to limit to your resources to the material you have to prioritize, and this could be very complex.
We'll talk
So I
more
agree
about
with that.
this.
Just
Go ahead,
one
Paul.
quick comment, and that is that, and it sort of follows on what Tony was saying, that even though if you look at MSI high colon cancer, back to colon cancer, I mean the overall response rate of the PD-1 inhibitors is not actually that astounding. It's that some patients have these amazing and very durable responses, and so everybody deserves an opportunity to have
to
that.
go for that. And I
Exactly.
call it sort of swinging for the fences, although it's
Right.
not. It's very solid, and we'll talk a little bit more about the incorporation.
Even though the
of
numbers
MSI.
are low.